Thank you very much for coming. I hope you will enjoy the next 2 days. I have the pleasure to introduce the panelists for this morning's panel presentation. But before, I just wanted to share something with you. When we do all of these clinical things, technology things, and all of that stuff that we spend a lot of time, we need to sometimes reflect and go back and see, why are we doing this? I'm a clinician by background, and sometimes when you have situations, scenarios that occurs, it kind of puts things into perspective why we do this. And this is a scenario that I came to, that somebody shared with me not that long ago. We know we're here for the patients because ultimately we as citizens and us as patients are all going to benefit from this. This experience came from a physician who was seeing one of their patients. And basically what happened is this patient had a lot of abdominal chest pain and of unknown origins. And so what they decided to do is, oh, we'll do a chest x-ray and see what's cooking, what's happening. And the chest x-ray was done. The results were sent by snail process, the lack of a better word. And basically it took about 10 days or so to get to the family physician's office. What happened is that this patient had a significant mass in the chest area, and that was why this patient was in tremendous amount of pain. So basically the patient was in pain for, by the time when the physician got it, at the end of the day, saw it first thing in the morning, saw the issues, send the patient for more advanced procedures to get the issue solved, and then the patient ultimately to the OR. But all of that process, the patient lost 14 days, basically 2 weeks of extra suffering and pain they had to endure, as if the physician would have received the information in an electronic format immediately in his office, it could have been dealt the same way. So when we look at that, we have patients suffering by lack of information, and that information not readily available. And I think the examples that the physicians are going to share with us today are going to illustrate how we can improve patient care, but yet also expedite the process. So I have the pleasure of introducing our three speakers, and I will give you a little overview of each of the projects, and then we'll ask each of the panelists questions, to which they will share their view and their perspective. So first I'd like to introduce Dr. Christopher Jew on my left-hand side. He's a family physician from Scarborough. He's also the Chief Executive Officer at Centenary After Hour Clinic. He is a lead physician for the East GTA Family Health Team, and is Chief Administrator for several affiliated physicians group. He also serves on the board of the Ontario Medical Association, Ontario MD, and the Canadian Medical Association. He also co-chairs the primary working group of the Central East LHIN. He is a lead family physician for Ontario Orthopedic Expert Panel, in addition to being a lead for the Diabetes Regional Coordination Center. He's a lecturer at the Department of Family and Community Medicine at the University of Toronto. Thank you very much for coming, Dr. Jew. Next, I'd like to introduce Dr. Sonny Cejic. I hope I'm saying it correctly. With the French intonation and accent. He's a family physician and associate professor in London, Ontario. He is medical director of a hospital-associated family medical center. His center is one of several core training facilities for family medicine residents, medical students, and often nursing students in the London area. Since March 2009, the center where he practices has been using the electronic medical records that are located on the Ontario eHealth server that's been funded by Ontario MD. For over a decade, he's had interest in using computers in medicine for practicing. He continued to teach colleagues and trainees skill for improvement in areas such as credible medical resourcing on the internet for providing patient care using electronic medical record, to name a few. He's a member of the Southwest Lynn eHealth Steering Committee and chairs the multi-centered Nightingale On-Demand User Committee that was formed after the implementation of the program. And in the middle, Dr. Brent Hesley, who's graduated from the University of Toronto Medical School. He's been practicing, he practiced medicine in Beaton, Ontario, Alliston, and he is now a family physician practicing in Innisfil, which is north of Toronto. Good shopping, by the way. And he's been working also at the Royal Victoria Hospital in Barrie, Ontario, for the last over the last decade. From 2002 to 2004, he was Chief of Staff at the Royal Vic, and since November, he's been working as the Medical Director of the Barrie and Community Family Health Team. Also, he's been in family medicine supervisor for the University of Toronto medical students and the Department of Family and Community Medicine at the Barrie site. Since some of his current projects that he's been involved in include interoperable strategy, which includes the hospital report manager with Ontario MD, partnership between family health teams and healthcare academic centers, and the use of OTN technology to connect patients and secure email for providing patient communications. So each of them we present today will be talking and using their reference of the project that they've been working on. There is a detailed deck of all this information. We're not going to go through the deck. However, it will be available on the website with all of the other conference material at the end of the conference. And I was mentioning the opening sessions. If you complete the survey, you provide your email, and you'll get directions on how you can get all that information. So it's like, we want a little something so that you can get some bonus out of this. So what I want to do is just talk a little bit about a high level of the three projects that will be introduced. In your presentation material, you will notice that there was another presentation, which is the Family Office Integration project, that, and the physician was planned to be here, but due to circumstances beyond control, that individual, that physician is not able to be here. So, but that information will be provided on the website for everybody. So what I want to do first is I'll just briefly talk about each of the three projects, and because you're not here to hear me, you're here to hear physicians that are going to share some of their experience. The first project, the Timely Discharge Information System. It's a system that's been in production and it's been used in Central East Lynn, Lynn 9. Over 12,000 reports are transmitted monthly from 9 hospitals to over 300 physicians. These reports that are transmitted include diagnostic imaging, consultations, pre-admission notes, discharge summary, progress reports, delivery notes, operating report, and some letters. The other project that we will have the opportunity to hear more in depth is the Hospital Report Manager. It's in pilot at this time in North Simcoe, Muskoka, and the Central West Lynn, which is Lynn 5 and 12. Over 20,000 reports are being transmitted monthly from 5 different hospitals to approximately 140 physicians. These report again includes diagnostic imaging, some medical and consultations, different consultations. The standards-based interface that is being used for that is now included as part of the certification process for all the EMR vendors that are providing solutions for physicians. The Southwest Physician Integration with the Regional EMR project, it's again in production in Southwest Lynn, which is Lynn 2. It transmits over 100,000 monthly reports on a monthly basis from 27 hospitals to 325 physicians. These again includes radiology, diagnostic imaging, laboratory, medication lists, and some other type of medical documents. And if you go back to the experience that I shared from, that I received from one other physician, this is an example that if that information would have been transmitted electronically, this patient would not have suffered the 2 weeks because the information would have been available readily in the physician's office. So what I would like to do is I will take this opportunity to ask questions, and each panelist will have about 5 minutes each to answer, and I will cut them off. So, and we will give you a warning 2 minutes before. Marion's going to give us a warning, but I will cut you off so that we have everybody's opportunity to chat and to share their experience. But you will have a rebuttal if you, should you wish. You will have an opportunity to follow through with this. So the first question, and with the automatic electronic data sharing that occurs, and that sharing a hospital discharge summaries and report to your EMR, your CMS or EMR, how is it improving your office efficiencies? How does it make you work better? And so we'll start on my left with Dr. Ju, and then we'll go through and talk to each of the physicians.
Thank you for asking me to speak on the first one. Obviously, there's a time. So I'm over type in my office reading all the paper stuff. I can go anytime, anywhere when I'm at minute free. I can look at the report online, hospital report online. And my office staff can just archive, assuming that it's already in there. The first 6 months, we're double checking, make sure we're not missing anything. And we're checking less often now because we haven't missed anything. Occasionally misplaced in different categories. But the beauty is for the physician, I can look at the reports anywhere. I can be, especially at home. I let that free up my office time, and plus that electronic download lab, that will save another chunk of my time, so that we can use, I can use it wisely to apply the advanced access and address other system issues that we need to see patient.
I'm going to use an example. I think I have a somewhat unique experience in that I sit halfway between rural Ontario and a medium-sized city in Barrie, a hospital, Royal Victoria Hospital, that is using the hospital report manager and thereby sends all 50 different types of reports directly into my EMR. Whereas a good number of my patients still use a small community hospital that has only 40 beds and has some imaging resources, but sends everything still to me by mail. To give you an example, you get a young couple, they're very excited, they just learned they're pregnant. She starts to have some bleeding, she goes to the small rural hospital emergency, they say everything looks like it's settled down, but you should have an ultrasound tomorrow morning. She comes back and has an ultrasound. She asks the technician, when will my doctor get that information? Because the technician is not allowed to give her the report, and so that she doesn't know what's going on. The patient doesn't know what's going on. The technician says we mail it to them. They usually get it a week. So the patient calls my office, makes an appointment for the next Friday to get that report. Next Friday, because the way things go, she comes in around 4 o'clock. My staff has a number of ways they can find where this information is. Is it still sitting in my inbox because I haven't got to it? Did it even come in the mail? Is it sitting where in some pile to be scanned now that it goes in there? So my staff has, and I don't have that information, has to go and look for these various areas. We come to the conclusion it hasn't come in the mail yet. So we call the hospital, but of course it's Friday at 4 o'clock. Everybody's gone. So at this point I have no way of getting this information for this young lady. I can tell her I get the information for you first thing on Monday morning and we'll give you a call. If, on the other hand, she'd gone to Royal Victoria Hospital emergency for the same problem, she goes in and has her ultrasound done at 9 o'clock in the morning. It is then dictated and is directly into my chart. My staff, who knows I'm not going to be until 12, can actually call me and say, can you look this up and tell us if we can tell her the information on that. I can access at home, I can access at a cottage, I can access in a number of different places my own EMR. I can then say to my staff, the results are all good, it looks like a completely viable pregnancy. You can let this young lady relax. She doesn't even have to come in today. So to me, in that sort of quick synopsis, is just all the advantages of being able to access information very quickly. It allows my staff, myself, and more importantly, my patients to get better care. It has given us all kinds of advantages. In my community, one of the drivers for other physicians, specialists in particular, to go onto an EMR is to have this technology, to be able to access reports almost, well, as soon as they are dictated and typed. So it's, for us, it's been fantastic.
I have to concur with my colleagues because it's very similar to what I'll be saying as well. The ease of access is the speed of access is the key to getting this information. So I have to kind of compare and contrast to get a couple of things. One to paper-based and one to scanning documents, because that's the key to this. In paper-based world, I think my colleagues have certainly expressed how different it is. And multiple people can view the document at the same time. I think that is very, very important. And my nurse, she can actually look at the information, she can put comments on it and start acting on it way before I'm even in the office. Now, the pro and con are we can access a lot of this information off-site, and it's there for us. And that's the con as well, because I worked on information this morning too as well before getting here, and it's always in your face. So that's good. The legibility is very important because during scan documents, a lot of times things get, the legibility might be decreased depending if it's certainly handwritten, because we do get handwritten reports still. And opening up a document, so simply opening up a scan document compared to text-based information is day and night. The text-based information is there, I can just quickly go through it, whereas the scan document I actually have to pull up. And our program is using TIFF files, so they're image files still, and we'll be to PDF soon. But that's a pro and con, because it takes you a lot longer to go through a scan image, and a lot of pulling apart sometimes to take a look at it. So I think I'm going to stop there, because I think my colleagues will express the most important things.
Does anybody want to add any other comments to what was just shared?
Nope.
Okay, that's good.
I can add one thing. You mentioned the ability to add information. With the software that we have, we can attach a task to that document so easily now, whereas in the old day, if you got a piece of paper, you had to write on it, you didn't know where it was going to end up. So attaching that and having a way to follow that is extremely valuable.
It's the tracking of pieces of information now that we can see actually, and who's done it. And if you actually send a task to somebody, but they're not to be able to do it, you can send it to groups of people a task too. And somebody, when they do it, they come off your system.
One of the comment that was mentioned was the fact that the nurse could access a lot of the information and also maybe start acting upon it. And that is a comment that I've heard many times, me included, as a nurse, is being able to have that contact with the physicians and being able to get their input in terms of how fast we can act upon some of the elements that were presented in the report. So again, you're going back to the timeliness access of the information and being able to provide services to your patients in a more regular fashion. So I will.
There's a question.
There's a question?
Yeah, trying to distinguish here, there's another category here. We have physicians who access the hospital system remotely via web or Citrix and all that kind of stuff. So they do have access to it. So I'm trying to understand the difference in how let's say we have a community who only, let's say 1 out of 10 bother to do that. They get a notification that someone's in the hospital, they can go get that data. So it's not there for them. And then there's that paperwork you have to scan, all that kind of stuff. So it's not very usable, but they can get at it. So we're really trying to distinguish also in this third category. Yes, they can get the information, but there's no convenient way to make it available because this push-pull thing is very cumbersome from the doctors. What hospital was it? Is there time now to take? Can you take a moment to look for that information? You can get it, but it's not so helpful, and then you still end up with that whole workflow process behind it. Eventually, put it into your EMR. So, I guess my question really is: do you have any comment about that? you know, that process and how it changes a physician's outlook to getting that information, if it's available in this fashion rather than a getting fashion.
Well, you're talking about more portals, so we have portals as well into our
Right.
hospital, so you can look at that.
Yeah.
I need that information right in the chart to be able to work with it. So you're talking like a Gmail account where you look at the email online?
Well, no, this will be remote where you actually can't see the hospital RVHS.
Yeah, so that's what
you
we
can
can
see
do.
the image, you can see the.
Yeah.
But you,
scan.
it's read-only. I cannot.
Yeah, absolutely.
That's the
That's
big difference. Now that it's in my system, I can use that information and actually start to act on it. I can ask other providers, nurses, colleagues, I can send that information out to allow them to act on that. I can ask this patient to do this, print off a lab to go with it at the same time. I want them to do this.
Yes.
They need the ultrasound said we should do a CAT scan. Let's start that process already. There's all kinds of, I can't act, I can look at what's happening in the
Right,
hospitals.
okay.
I can't act on it.
Okay. Yes,
Can I ask
questions?
something? So it's Glenn at the Southwest Lynn. So you're asking a very good question. And why? Because the debate has always been, should we have a portal out there so physicians and clinicians can access data based on where it resides and have a view of it? It seems though with these projects in the primary care world, they absolutely need the data at the point of service where they're at, right there in their office or with that EMR. And so what may come out of this session too is allowing the physicians to use their EMR as one place to go in the primary care world is working really well. In the rest of the world, there's the big debate about where do physicians go to get their information. But in a primary care clinic, having all that in the EMR helps with the adoption, the use of that tool, and the interface enables that far more than anywhere else. So what we see emerging in Ontario is physicians in their offices, GPs in particular, like to use the EMR, and that's where they want the data. Other physicians want tools where they can scan across the healthcare continuum and have a look at information from either the community or a hospital, put it into a portal, and have a look at it that way. So two different approaches I think that are going on right now in Ontario. But the debate about should it be in your system or at a place where you can go view it is raging on, but the place that it's working well in the system is in the GP world, it seems.
And just to add to that is that in the GP's office, they have additional information that may or may not be available in the hospital system because they may have seen the patients for 20 years and they have history and all that information. So when that one piece of information that they've received from the hospital, that may totally change the picture because they're able to look at everything else with it. So you've got the longitudinal record that is in each of the physician's office. That's just my own personal thought. There was another question.
Having a comment?
Oh, comment?
We had a poll technology before, but nobody's embracing it. It's a workflow issue. Having 2 minutes sit down in front of the computer, logging my username, password, pull the information, I don't want to do it. But if push is already in front of me, I'm there, patient's in front of me, it's right there. It doesn't take me three seconds to look at it, and that's working. So while project TDIS started with a different perspective, this is a primary care driven one. We started with a whole Central East in 9 hospitals with the ultimate goal linking in. Whereas I believe Barry just Barry Hospital and Family Health Team. So our biggest challenge, this is not mentioned anywhere, but this our biggest challenge, my work for the project is actually get a service level agreement to have CMPA covered physician signed on to it. That was the most challenging thing, and it was never done before. So all doctors will have to sign a service level agreement with the hosting site, Ultra. That's covered by the CMPA. I went through a lot of hoops to get that approved, the first one in Canada. Then the hospital deal with themselves. They have master agreement with other 8 hospitals. So that's a public information, just in case anyone wants to use it. For the service level agreement with the hosting site in the future, that can be copied because it has a stamp approval at the CMPA. All thanks to partners at the Central East Health Office and Alberta.
And we have one more comment.
Just a quick question. So at the Toronto Central Lynn, we're looking to move forward with this type of project as well. And the approach that we've taken is that we think it's absolutely critical for transition of care reasons to have the information from hospitals sent to primary care physicians. But now that you're live with the system, one of the other pieces that we've been thinking about is the quality of the data and the reports that you're receiving. So things like standardizing the content in, for example, a discharge summary. Have you come across any issues, or do you have any comments on the importance of standardizing data or the quality of the data that you receive from the multiple sites that are sending the reports?
I'll like to comment. I can give you a few critical points. It's 99% functional, but the 1% that drive you nuts. For example, it's all EMR dependent. It depends on who's your vendor. Our main vendor cannot print directly what I'm seeing that. You have to go outside, extra click, you print. And sometimes you want to edit because it wasn't the part of the body that actually describing. Once you edit, some of the other features disappear. So I point out to my vendor how screen who's bought out by the Optimed now. And because of their financial problem, they really didn't get onto developing that, finishing that little bugs here. Overall, seeing it, printing it, it's okay. Except when you attach a referral, you can attach scanned documents, but you cannot attach the imported image documents. That's another challenge. Those are the major irritants to physicians. I have the data inside, I have to print it out, fax separately to a consultant. That's another attachment.
Okay, I think, Dr. Ingrid?
Well, I think it's a little bit pure in our system because we only have one hospital, so it's dictating it. So it's the quality of, it's all text-based, so it's the quality of who's sending you the reports. However, I have found that when physicians now know that they're being observed by others, the quality of the work goes up. It's sort of like keeping score on also. Sure.
A couple items on that, because we were the one of the primary sites that turned on, when they turned on SPIRE as an alpha site almost. We received everything, right, coming from the hospital. So it's going to be very important of what you actually want to get from the hospital, I think. Because we were receiving IC reports, every half an hour we were receiving blood work, CBCs coming in, this. So we said, well, we didn't receive that in the whole paper-based world, so we don't want that. So we get outpatient blood work, and we get imaging, anything we've ordered or outpatients had ordered, and discharge summaries as well. That'll be one of the keys, is just sitting down and just trying to figure out what information we actually need from the hospital and what we actually need to act on. And on the standards question, I think that's very important. That's something I've certainly talked with our SPIRE continuers to create on. Something not too structured, but structured enough, because when I get a discharge summary, like somebody goes in, has their appendix up. So now I have this blob of text. So it's great because I can actually highlight text, I can cut and paste it, put it in an alert, do different things. But if it actually says appendectomy there, it would be nice if that was a structured field. I can just click it and it goes into my Clement patient profile, which in the family physician's office is patient summary information. And the big one is the medications, right? Because I can't reconcile medications unless they're really structured. So I can see the structured list coming and my medication list and kind of jamming together, and then I'm kind of deciding, trying to make sure that there's only one medication list. And so that'd be a great structured field. But we can't structure everything because we just need to make sure that there's some flavor to the note too. And it's still in that format, so we're always looking for that structure.
So Dr. Cejic, following up on this, has it made a difference in how you work in terms of how you see patients, what is your process on a day-to-day, and if so, how have you changed the way you work, and what have been some of the outcomes of those changes?
So in our practice, and just continuing on these points, is so the information before I would receive in a paper-based world, either my nurse or myself would receive the report. And then, and a lot of times I would be sitting in my box too, in the paper-based world, and we would be scanning down through the box, just trying to figure out what's actually important through there. In the electronic world, we can multiple people can access the record. So she can take a look and she can start deciphering what she's actually going to do. And if the cardiologist said that I'm discharging you on Lipitor, on a cholesterol-lowering medication, and in another 3 or 4 weeks I'd like the lipids done on this person, so then she can start acting on that and doing that for me. And there might be other little nuances through the note that I will highlight, and I'll cut and paste it over into the alerts. And this is very important in our teaching practice because I want to make sure when that resident doctor sees this patient, because I check to make sure they have a follow-up, to make sure it's in their face that this person might have something that needs to be done, but I want to make sure it's done. In the old paper-based world, I had to put little stickies next to the chart and say to the resident, I want to make sure all those stickies are addressed when a person comes in. And this way, at least, there's multiple people checking the chart. So I think there's more checks and balances in the system, and it's very easy to see. And it's all standardized, so you know exactly what you're looking at. It's not here, there, or all over the place. I think that's very important. I think this is a lot quicker for me to review, too, so that's where it's really changed. Reviewing text-based information and just, you know, there's only a couple of keystrokes I have to hit to sign it off and move to the next one, sign it off, move to the next one. Exactly like I do for blood tests and stuff like that in an electronic chart, which is very different than I did in the paper-based world, because in the paper-based world, I had my electronics, but then I also had the paper-based stuff that I actually had to highlight and do different things to. So it's certainly increased my efficiency a lot, and safety, I think, for the patient's sake. And patients love it, because they can see, they have some confidence in the system when they're sitting down with me, and I'm showing them these records, and they can see it. It's all the same as their other entire chart. And I think it's really builds confidence in the system. And I mean, it comes there. So I know when they're discharged, that they actually, when they come to my office, you know, a few days later, I can act on the information that's in front of me. Whereas before in the other system, it was somewhere, or it might have made it to my office, but I still have to figure out what point it's at.
Have you found in that process, because I remember the paper world, I'm not dating myself, thank you. One of the things that in the paper world, some of those pieces of paper would come in, would sit in a pile, and then somebody would eventually put them in a file, and then you hope that they would, and everybody's human, and then sometimes the file, the reports, does get misplaced in another patient's record. Have you found an impact in terms of how you work, because you've got less missing reports, less errors in terms of reports being in the wrong chart, which doesn't happen often, but it's the one that happens that is always the key.
Definitely less errors.
Yes.
Yep. Definitely less errors, because the sorting seems to be okay. I haven't found any errors in our circumstance. We have some formatting errors when you're actually going through the growing pains and information is coming to you. But after this, no, at least we've eliminated that component of it. I mean, the key is being able to find the information. And that's the paper-based world. And the scanning world, so I have to compare always that to. The scanning world takes a bit of time, because we get the paper stacks first for the information that we actually have paper-based. And we actually look at that first before it's actually scanned in. Because it's scanned in within 24 hours, but it's, you know, it's 24 hours that report might not be available to you for the rest. And those circumstances too, I'm highlighting sections in highlighter, and that gets actually typed in the comments box, because that's an easier place to see when you're looking at these reports, rather than clicking it on and opening up the entire report in a scan-based world or in an image-based world. So that certainly sped up that process too.
Okay, great, thank you. Dr. Elsley, how has it impacted how you perform patient care overall, and has it changed how you deliver patient care within your practice?
I think we've touched on this a little bit. I think the one situation where it really has impacted is those urgent situations when you need the information as quickly as you can. Examples may be when something's happened to a family member and someone else comes in and they need an update, and you're still waiting for a report from the hospital, whereas now we can access what happened in an emergency the night before, what imaging was done, what lab work was done. That in those sorts of situations, it's extremely valuable in a family practice setting to be able to, often in a family conference, deal with what happened to grandma last night in that situation. I think the other thing that's happened in primary care, and we've alluded to this already, is that there's a change from isolated physicians working in isolated spots to physicians working as parts of groups. We're now parts of teams, and it's extremely valuable for the other members of the teams to have access to this information. By coming in directly, it's not sitting in my inbox or in the scanning pile or somewhere else. It's already in the chart. Even if I'm away, I haven't been able to get to it yet, and that allows other members of the team to continue to function. I think those are the two biggest impacts on patient care.
Okay, thank you.
Can I add?
Yep.
Exactly as we're practicing in family health organizations or teams, we're physically located potentially in different offices. And this report now in your family health team is available after hours to the other person that's actually on call for you, which wasn't in the paper-based world. I mean, we had our isolated charts in the offices, and they had to make decisions based on no information at another site. But now we can actually share this information, so that's critical.
Thank you. Dr. Ju, do you have any anecdotes that you would like to share with us as to how it has made a difference and improved how you practice, within your work environment, and improve patient care overall?
Well, I can't remember any particular story to tell about how good it is, but we know it's sort of been using it for a long time. You just intuitively you get used to it. You can't remember so many good things. The stories are too many. What I do want to share with you, going forward, perhaps, ministry is the home first philosophy, and programs coming out of it rely heavily on the timely and speed of discharge information from the hospital to the primary care provider CMR. The reason is very simple. Now, there's a funded RN position for discharge planner now at hospital. Then the discharge planner, I'm the advocate saying, don't just send them home with a script. I want everyone going home with an appointment date. Be the urgent first week, less urgent second week. So patients go home with two things. They feel comfortable, they feel safe, they don't have to do extra work. And on the other hand, the specialist feels safer to discharge the patient 1 or 2 days earlier because he or she knows what the family doctor is going to read the discharge summary in reasonable time. Therefore, can say, wait, watch the weight, watch the salt intake, do this, do that. We can avoid the emergency visit and speed up early discharge. It's confidence. This is actually one of our projects actually going forward. Those are going to be rolling out. So you see how this piece tied in, how important it is to have early information. If we rolled out an entire province, everyone's expected, that's the standard of care, that you get information. The challenge here is now, the first few days, to have that information shared by CCAC. Patients will be looked after, daily visit, fully change, IV medication, checking on the status. To have that information shared with CCAC, which is not permitted at this time. So we're working on that.
We're all working on that. So I guess one of the key things that comes out, and I refer back to Shirley's presentation this morning when she mentioned, is the key is unlocking the data and making the information available for people. And I think all the examples you share all go along those lines. We've talked about how you feel and how it has improved how you work, and this is a question for everybody, and maybe we'll start with Dr. Elsie. How does your staff feel overall in your office? Not just yourself, but the nurses, the clinicians, your administrative support staff, because this must have impacted their work. And how has it impacted their work? What has been the outcomes from their perspective? And how do they feel generally?
I will start with my admin staff because they really run the office. The first thing is obvious, there's less filing. And they keep asking, when can we get other systems reporting the same way so that there's no filing? Because of course, scanning is just a different form of filing. So they've really enjoyed that aspect of it. However, I think where it really impacts for them is that they are more comfortable when patients call in and want to get an appointment to review information, that sort of stuff. They're much more comfortable knowing that they came from the hospital, that information will be in the chart. And when that patient comes, they won't be spending a lot of their time trying to hunt down where that piece of paper has gone missing, or isn't even here yet. I think what that does, of course, then it frees them up to do other activities around the office, develop recall systems and that sort of thing. And I think the other key factor for my nursing staff has been mentioned is that they can access information and prepare for the appointment, prepare myself for what activities have to be involved in the interaction with that patient. The other staff that we interact with are other members of the family health team, so our pharmacists, dietitians and that sort of thing, who are often in a different location, but they're able to access information timely when they need it, when they're working with that patient. So I think those are the main areas in which the staff benefits.
Yes.
I think I'd echo exactly. My nurse is very happy and all the staff is, because you get the information just in time when the patient's there. the most frustration is actually patients arrived, and then you're running to find where the information is because you can't actually find it. So I think that's very important. Who really didn't like it as much as my admin person, because I have to actually, a lot of times when I set meetings with an admin person, she knows that it's not going to be good news because we're cutting hours, right? We're cutting hours of filing. We're not filing after hours, so this is money that we're actually saving. Unfortunately, I'm trying to train this person to do different things, as we have a lot of preventive care stuff, a lot of other things we're actually doing now in primary care that we weren't doing before. And so there's a lot of job retraining in my admin person, so their job description keeps changing all the time. And this is, they're more happy about that, but we still definitely in our clinic has decreased the amount of hours for filing and the amount of time. So we're reducing it more down to part-time work more than full-time work. So that's been kind of a negative for them, certainly positive for us.
And Dr. Jim?
Well, I found that I go around teaching my docs, saying the first year you're going to find out you need more people to do your stuff. First of all, they have to get on the speed of EMR overall. You require to enter the phone number, fax number, pharmacy now, before you pay, or you don't, you just write down there, that's it. And you have more entry data. I'm more obsessed with patient cell phone number, home number to be accurate. And so they spend the first year scanning the information, and I tell them, all my docs, expect to hire an extra person the first year to scan, and keep the person on converting the job description to something else. My colleagues, they have alluded to. Preventive care stuff. You always got things to do. So it is increasing the quality, efficiency of the system in the office overall, satisfaction, safety, but also you need to invest a little bit to that. It's a balanced world. Yes, your office, your lifestyle is a little bit more efficient and not as stressful. You don't carry heavy charts, 10 charts go home to do the work. During the weekend, where it's just a piece of paper with 10 names, you can go home and look it up and even build WSIB online now. And this is all beautiful things, but then on the other hand, there's a bit of investment on your part to get that benefits. It's just not free lunch.
Okay, thank you. And
just on that same category, when you receive this information, are you happy with the classifications of these files and documents that you get? How cumbersome is that for your staff? I mean, consultation, who's the person who did it, you know, and does that integrate well, I guess, with your EMR, that information?
It is in our system because, so we get 50 different types of documents from Royal Victoria Hospital, but they come in as document and then a label with that. So it may be mammogram, bone density, CT scan, abdomen, that sort of thing. So to be able to access that very quickly, you can highlight it to get more information, and then you can expand it completely to get the information you need. It actually is a much better system because it's been centralized at the Royal Victoria Hospital and was worked on by Ontario MD. My old scanners, depending on who's doing the scanner, you might got a different tagline to that document, so it actually is more consistent now. That's what I found.
One of the things, I'm just going to step in, one of the things we did with through Ontario MD is standardize the categorization, because physicians don't have time, you know.
That's extremely valuable.
So every ER in the province, when they are certified, will be able to auto-categorize whatever procedure, name, or whatever comes from the hospital. Right now, we don't have a standard across the province, so it's a painful process to do it initially, but as we implement, that categorization is built in.
yeah, and that's going to be, I think, key. Not as much when you have like in Barrie, you have one hospital, but if you have an organization in which you get reports from 5, 10, 20 different hospitals, that becomes a really issue.
And we do. We have current family health teams who are getting reports from 3 or 4 different hospitals.
Can I just elaborate on the categorization? Categorization is so important, it's critical for future data mining. I'll give you an example. I have eliminated certain duplicated information in our system. We have one choice cardiogram, the other one called EKG. And certain staff called label the cardiogram, certain staff called EKG. So you have no consistency when you do mining. So therefore, I took pain to go through all the description. There's only one person allowed to change the description. So you find a mammogram, not breast mammogram. So if you different categories of the same thing, you cannot do data mining well unless you're purposely doing that and then mine both at the same time. So this is important for people to, when they use the system, offset this. Having said that, hospital currently also vendor dependent. Last week I found out a pulmonary function test with the consultant tab. So usually there's a procedure type. It should be going to the procedure. You can, all description, pulmonary function test, cardiogram, stress test, all on one tab. So you sort out the test. And then this is all a vendor dependent thing when you mention. Be careful. So that's, like I said, it's not 100%, but 99.99%. If that little 0.1% that would make you a little irritated.
But that's very key. You need some, I think that's one thing that I don't know if exists, is a central organization or group that will be dictating these certain standards. Because physicians are so much like herding cats. You're right, if you're going to write ECG, it's going to come out, there's 4 physicians, there's 5 different ways of written, right? So I think that's extremely important. I'm glad that someone in your organization just said, I'm your boss, and that's the way it should be. That would be beneficial in a lot of areas.
Yeah, categorizing standards are very important for also preventative care work and quality improvement initiatives, because that's what we're actually doing more and more of. And it'd be very nice for women's care to have the mammograms, the PAPs, all probably posted to our central kind of CPP, which is Cumulative Patient Profile, the summary. So I know that they've been done automatically if they come in as a result, but that automatically gets posted there, so I know it's been done. Or all-call blood testing after they're over the age of 50. So there's certain maneuvers that we do, and actually we're reimbursed for it as well. So there's other things driving us too as well, for this financially as well as helping out patients, that we can actually post to there. So pulling it out of there and posting it would be very helpful for us.
Okay, good. Any other questions? Okay. What would be your recommendations to physicians who are embarking on this journey? And what would be some of the key elements? We've talked about standardization, so I assume that would be one of them. But what would be some of your other recommendations? Maybe we'll start with Dr. Chu again. We'll start from my left and go towards right.
Well, I'm a soft person. I don't like to hit physician with a stick. But I always give the example of saying that, you see, ministry has withdrawn the claims, paper claims submission. Ministry has recently discontinued the scan submission, EDT. And we all know it's unsafe to have handwritten prescription mistakes. We don't need to study the literature, it's there. And nobody can read it, duplication, phone call. If you do start with electronic prescription as a first step, and perhaps that's better for your patient and save the system money. And also ask the question, do you really want to go back to the old days lining up at the bank teller to do your deposit, or you rather go to the machine when you are free? So I give a lot of subliminal suggestion. I don't think that's quite subliminal. Long enough to make them think. I also say, if you have 63, if you don't convert, take 6-9 month thing, convert, you're not going to find a young doctor coming into your solo practice or small group practice taking over. They're just going to go by. What are you going to do with your patient that you know for 30, 40 years? Don't you feel bad? You know, I do the soft touch. But then I try to show them all the good stuff. I say, it's great stuff, you know? So, but I do imply to them eventually, it's like Obama, it's mandated. By 2015, US, they have to, or something like that. But US is more forceful, and the European countries are more forceful. They pass the legislature. But inconvenience, we like the commission, we like to study, we like new periods, times, money, still don't do it, I don't know what else to do. I personally not in position to make comments for this association, but I don't think we should twist the arm and force a doctor to do that, but you should give them lots of incentive, lots of reason, collegial pressure, and reason with them. Go for your patient, go for the quality of care. At the end of the day, that's what we went to school for, looking after the patient. Thank you.
In my community, I've not had to push other physicians to come on board. It's quite obvious the advantages of getting the records. Their request is, when can we get other sectors on board? And when can we do the reverse? When can I look into my specialist colleagues when I be able to access information from my charter? That hopefully will be phase 3 of this project. I think clinicians get it very quickly, the advantage of having data on time, when you need it, where you need it. I don't think it's a difficult sell. There is, as you said, some costs. There's a learning curve for anyone who's coming on board. They have to get involved with the DMR, which is a big project on its own. But I think that more and more physicians are understanding the advantages where it really matters is in clinical care. So I think that's the biggest selling point.
I think getting it just electronic and knowing that you can actually get this information without scanning it is probably going to push the adoption rate higher, simply because that's one less step to do, and a lot of the advantages we discussed too as well. The one little caveat about all these projects that we get this just-in-time information, and I'll give you an example from one of my patients that I've been taught. She's been a patient for me for a long time. She had breast cancer, and then so the surgeon is watching her very closely, and getting paper-based reports takes a while. So in this circumstance, she came in for me and she just saw the breast surgeon maybe about 3 or 4 days ago, just on a yearly follow-up to make sure everything was okay. And then they did a mammogram on her the next day. And a paper-based, and the third day I saw her for her high blood pressure. And usually it would probably take about a week before I got the report back. But here I am, I have this report in front of me, and she's going to be seeing the surgeon the next week to go over the results of this report. But now it's in my face, right? So, and I see that there's actually a new breast cancer, right, that's formed. So now, do I take over this breaking the bad news or not? Ethically, I have kind of, I think, a responsibility in front of here, right? But I don't have all the information too, because the breast surgeon's been following her and what to do next. And this is a Friday too as well, so obviously you're going to cause a kerfuffle over the weekend. So you have to deal with an individual basis. So this is the difficulty. We get a lot of information now, faster sometimes than the specialist will actually, because they order the test, but they don't look at their records. It takes them a while, but it's in our faces. And we have an obligation now to act on it as well. Before it was whatever doctor ordered the test was the doctor that actually was responsible for it. So I could just wash my hands and just say, no, I'm not responsible for it, whatever happens, happens. That's not it. There's a shared responsibility now. When you get blood tests, other things coming back, because I've had dropping hemoglobins, that's obviously how much blood you have inside of you, that are coming down critically, that have been done in an outpatient clinic. That patient hasn't seen me, but I've got that information. So I have to make sure my nurse and myself call over to the other doctor to make sure they're dealing with it, to make sure they're not on vacation. So there's a lot of that happening now, because I get this information very, very quickly. So it's really changing how I practice as well with our patients.
I would echo that, because what has also happened is there's an increased expectation of our clientele. Our patients are getting very quickly the understanding that that information is there, or it should be there. Why don't you have it right now? I think that there's going to be that aspect of having to deal with. It's something we didn't have to do with before, so it is going to change our culture as family doctors. We are going to be even more on the front line sometimes.
The expectation of our patients as they come in, they see we're behind this box, is we can see everything.
That's right.
Right. So that's the expectation. That's what
or they think you can.
Not the expectation, but the assumption.
The assumption.
Yeah.
Have any, talking about your patient when they come to see you, have patients made the comment that this box, the screen, that is interfering with the care because they feel instead of writing that you're looking at a screen and reading the screen, because in the quote old ways you would have a chart, you would write, and you can talk to the patient at the same time. Have they made a comment that that has interfered? Maybe we'll.
Only when they were laughing at my typing. I think that was something saying, this is really hard on me, yes. But I think it has been an interesting experience, because there is now another person in the room when you're doing, that wasn't there before. It's actually something when I'm training residents, family doctor residents, I have to encourage them to remember that they're not interfacing with the computer, interfacing with a patient. And sometimes you have to continually drive that home, because there's a whole lot of information here that they're trying to deal with. One of the struggles, I think, for new physicians coming on board is to be able to use that as a tool, like your stethoscope, but still maintain your focus on the patient. And that can be difficult sometimes.
Yes.
During training, we certainly view our residents. I think we do it by camera. We do different ways of doing that to make sure that they're not just interacting with the computer. And every doctor's going to do it differently, but usually my experience with our learners and myself too as well, I'll get the essential information down in the note, and then the charting is done outside, usually in my room, in my office or somewhere else like that, or even maybe toward the end of the day. But I get the essential information down first. And for patients to not, you know, if I bring on a paper-based chart or something else, I think that they definitely do not think it's state-of-the-art. And everything else is going electronic. And if they can read it with me too. Now we have, I don't have any mobile units, so we're actually having thin clients, and we move the screen back and forth, and we review with them. So they're 19-inch monitors, so people can see it. And we go through it together, and we change things together too. So it's kind of a process together with this computer. It's not in front of me either. So, and they've done studies even in our university about this, and it certainly has not deterred. I mean, it has enhanced patient care, unless you're interacting with the computer all the time.
My experience is similar. I have my patient engage with what I'm seeing in the past. I was sitting across the table, charting, talking to the patient, and do the charting after they're gone. But now I got a 26-inch screen, having a swivel arm, and if I have a trick saying, "Oh, can you help me find out where's your name?" I get patient engaged. Saw the name. I was click. That's what. See the report here. And they start reading it. They're not looking at me anymore. They're looking at the screen with me. So while I'm quickly doing my things and getting them attention, so they become part of the visit. They're actually helping me. Oh, my name is there. They can see the name faster than I can. So I get them interested in that and start sorting out things. So they don't feel bored anymore. It becomes a little video game, sitting side by side, or looking through Google, the same thing. And in a collaborative environment, you can afford to have more time with per patient, because I negotiate with them, seeing them less often. So I shuffle my time that way. But per year, in terms of per year, I still see the same, but less often, longer. So I can play the Google thing and search for that few things. Not all the time. Once in a while, they get interested. Every time, let's see what's happening. With the next visit, they make more interesting. Look at big screen. 19 inches, I thought looked too small, so I got one big one.
I made the mistake before too that our elderly patients aren't on the web and they're not interested in this, but they certainly are. They have a lot more time, and I will insult people if I even think they don't. I'm copying out websites for them, or just keywords, because I'll just do it in Google. Copying out websites, that's impossible because they're going to get something wrong in syntax, but just give them keywords and they'll find the information. So.
As you were speaking, a number of years ago, I read an article that was published, and I wasn't alive at that time. It was published in the Lancet in the early 1800s, about 200 years ago. And when it was published, there was this patient talking about this piece of equipment that was interfering with patient care, and how that thing wasn't sure what it did or how it did or what it was supposed to do. Anybody has a sense of what it would be?
Yes, we know it.
The stethoscope.
The physician used to put his head right on the patient's chest and listen.
And listen, and the stethoscope was interfering with patient care. Now it's like you don't even think a stethoscope is part of life. And I think that seems to be some of the direction as we include patients like in the care through the use of technology moving it forward. There's a question about.
Yes, I was wondering if with all your access to these reports in such a timely manner, whether it's affected your workflow, or whether you're incorporating more email in your practice in terms of communicating the results with your patients.
We haven't gone that way yet, because we've been sort of directed by our college that we're not supposed to be transmitting personal information by email. Patients don't understand that. They don't understand that it's not secure. It is a tremendous temptation often when I know we've had to deal with allied health people following up diabetic blood sugars and adjusting insulin. They think it would be much more efficient if we could do it that way. That is another thing that hopefully down the road someone could develop, a secure patient portal. Another wish.
So for our record, because we're under a hospital, we still have a lot of privacy issues and security issues to overcome. But our record can be just turned with a switch just to have patient access on it too as well. So this is where all my messaging, so if I get a blood test back, like a cholesterol, in the comment box, I have a patient comment box, I can see your cholesterol's a little high, here, go to this website, learn about how to deal with your diet, and then if the patient portal is active, they get a message in their email saying there's something in your health account. So then they go in, they log in, and then they look at the message, and I know they've looked at it too as well, right? Same thing if I want to recall a patient, I can actually do that. But I make sure that they've actually seen it. That's the key to this, right? Because you have to make sure they've read it. And or just do it with an internal messaging, right? So that's going to be a big plus. I mean, I can't wait till this technology expands, and obviously I'm an early adopter, but in the home, and we get, you know, the telemetry device, because everything's going Bluetooth, and the next spec of Bluetooth 4 has a lot more encryption technologies and everything to make sure that it communicates securely with a lot of these devices. So I can see, you know, with your insulin meters, with your blood pressure cuffs. I mean, when I do the presentations, I jokingly show the smart toilet from Japan, because you can sit on there, it takes your weight, takes everything in the morning. No cameras. But, and then you can imagine that telemetry information sent back to me, so I can look at the person's glucometer results and everything, just like it would be on a lab, normal lab test I'm doing now, and act on it, just send them a message if they want to do it that way. So I can deal with them at a distance if I need to.
Just one last question. One last question is, you mentioned that receiving the reports from the hospitals and sharing among, like within the practice. How is your workflow when you work with specialists who do not have an AMR and do not have that access to that, like that it be a surgeon or an orthopod or whoever?
Like the old days.
Like the old days.
Print it off and you fax it if they're that advanced. There are some who are still, you have to mail it to them.
Yeah.
And a couple you just have to walk and find them somewhere and hand it to them.
I mean, if they're in the hospital, they're dictating, so it goes into the system. So mostly.
So in the hospitals, it's
it's not a problem.
It's not. It's outside of it.
Outside, it's scanning. You have to scan that report.
Okay. Yes.
So there's some work going on with OTN to try to bridge that gap between the GPs and the specialists so that they can look at doing exactly what Helen's saying. And they've been looking at maybe using SPIRE to figure out how to message more securely between the GP and the specialist. And they've got some projects now with dermatology and ophthalmology to bridge that gap and use maybe the SPIRE messaging engine to send it off to a site where the specialist can go and look at it, because they don't have the tools that the GPs do, not as extensively. To the point made earlier, so the specialist can go up with the portal after message, have a look at the consult, make the assessment, and then that'll come back to the GP. So we're looking at using the technologies like SPIRE and probably others to be able to do that. So OTN right now is probably the ones doing more of the work right now in Ontario in that space. So they're the ones that are kind of getting by.
Thank you. And you have the opportunity of asking the last question.
I think it's all already been answered.
Oh, okay. One last question? Yes.
So I think we've got 3 different platforms that are doing something that you all find very valuable. The question would be, if the physician had a choice, how would they determine which one they would go with?
Oh, I like that question.
If they had a choice, if they don't like it.
Yeah.
Actually, we were discussing this, okay? It's which one shall we pick? The problem is roll out. Actually, the answer is very simple. It's just to be treated as an add-on feature of any program. You have 3 different add-ons. Roll it out, the vendor will adopt to adding 3 different add-ons. For example, Optimed, parent of the health screen, just took over. They are engaging with Central East Lynn add-on to the TDIS. They are already certified for the hospital report. It's not a lot of investment for the vendor. They just have to adopt 3 different add-ons as a part of the EMR feature. It doesn't really matter where you go, who you sell to, vendor. They already have 10 vendors on them, and each vendor carry on 3 different add-ons. I think that would be the way to address that issue. So no competition, rather cooperation. No fights, no turf battles.
You're asking about our interface. I think they're specific to the location you're actually in,
Yes.
right? So far, so I can't go with anything but SPIRE. Right? So.
But one would hope that they would take best from each and create one. That would be really.
It's
You're
not
dying
creating,
to ask another question.
if you're creating one, you're going to cut competition thing. Rather, we should set a framework, a standard. Everyone must meet a certain minimum requirement to move on. I mean, this is regional responsiveness, regional needs, and regional, I guess that's why we have the links in the first place. So we're not want to defeat the regionalization concept. having just one monopoly. And if you one monopoly, you get a different problem, and jack up the price. So let them compete.
Because I'm in London, Ontario, if somebody's going up north and they have an accident in Barrie, and I don't get that information back, right, through this interface, is because I'm in London, I'm SPIRE, and I'm not a hospital report manager, right? So it's very different. So we need to come to one system, right?
Okay. Glenn, you're dying to ask the last question.
Jenny can answer the question.
Yeah,
She's about to answer the same thing she's going to say about where this is going in the next year.
So you guys know the answer?
I can give you a little bit of the answer. What, if you're in the SPIRE region, we're in the process of moving the SPIRE interim solution into Ontario MD's solution, and then eventually going to the hospital report manager. If you're in TDIS, you're going to continue with TDIS for now. What we're trying to do is all work together to come out with a standard EMR way of receiving the data so that you don't have all these different interfaces. And that's why the spec has the standard XML format. That will be the way we try to go long term, but we don't want to stop the adoption of an EMR. That's the whole focus, is to get doctors on board. So, you know, long term, yes, we're going to try and go to one standard. How we get it there, we're just not sure yet.
And I think you made a major point is for patient care, we need to do what is right now,
Exactly.
but look at the future where we want to go. We know we want to be there, we're here, let's do what we need to do now and move towards where we want to go at the end. Okay. Well, on behalf of HIMSS Ontario, I would like to take this opportunity to thank our three panelists, Dr. Elsley, Dr. Cejic, and Dr. Ju. Thank you very much for sharing your thoughts and experience with us.